One general announcement: if you don't read the New York Times, you probably ought to, because your parents will begin to ask you about rapid genetic diagnosis in newborns, a topic of that session. This is another of our ethics grand rounds, and I'm going to turn it over to Ben Wilfond to make it happen.
Good morning. Nice to see you all here early on a Thursday morning. For those of you who have come to our ethics grand rounds in the past, commonly we identify a case and have a presentation of a case and have an outside commentator discuss that case. But once a year, we have a special ethics grand rounds that we call our Truman Katz Lectureship. And that's a slightly different approach and different format. And for this grand rounds, we invite a distinguished person from the field who we would like to sort of have a more broader conversation about important ethical issues in pediatrics as an opportunity for us to meet that person and for that person to meet us. It's also an opportunity for me to spend a few moments, for those of you who are new to the institution within the last 6 years, to talk about why this is called the Truman Katz Lectureship and who is Truman Katz. Truman Katz was the former CEO of the hospital, and I will say a little bit more about him with these slides. He was the president and CEO of the hospital from 1979 to 2005, and he really changed the way Seattle Children's Hospital functioned over that 25-year period. He really moved it into the current generation in terms of strong fiscal management, and really secured a lot of broad-based community support for the hospital and for the hospital's growth and its position within the community. And he's also developed many new and innovative programs, many of which we take for granted now. So a few of his many accomplishments include the fact that we now have a very clear affiliation with the University of Washington School of Medicine. As many of you know, Seattle Children's has existed for many, many years, since 1907, and so it took a lot of effort to make that change occur. He also was critical to the development of the Seattle Cancer Care Alliance, a partnership between Seattle Children's, UW, and Fred Hutch. And specifically, he has been an advocate for issues in child health, injury prevention, and early learning. And he also initiated the development of Seattle Children's as a place for doing clinical and basic science research. So I want to say a little bit more about Truman Katz and ethics. Truman has had a long-standing interest in a number of issues that really underlie a commitment to bioethics and ethics. One is the issue of quality of care, of how do we improve our quality of care. The second, how do we respect the role of families in decision-making. And he has had an appreciation of emerging areas where ethics becomes critical in clinical research as well as complementary medicine. And so at the time of his retirement, through a number of discussions with a variety of people, including Jim Hendricks and Doug Diekema and Bruder Stapleton, there was a decision to create the first Center for Pediatric Bioethics in the United States, and the Board of Trustees created an endowment in honor of Truman for the center as well as for this lectureship. And so I've been very pleased to be here for the last 6 years, working with Doug Diekema and the rest of our faculty, leading the center. And I'll switch gears now and just talk briefly about Ruth. But before I do that, I need to actually acknowledge Truman is here in the room with us. So Truman, thank you for all of your support over the years. For those of you who haven't met Truman, this will be a chance to meet him and see him as well. So let me tell you about Ruth Macklin, who I'm quite excited to have join us this year. Ruth is somebody who I first heard about when I first got interested in bioethics quite a number of years ago, and she has been writing in this area for a long time. She is trained as a philosopher. She got her PhD in philosophy from Case Western Reserve and was on the faculty there for a number of years before moving to the Hastings Center, which is one of the first bioethics centers in the United States to focus on bioethics. That's why it's a bioethics center. She was there in the very early years, and then about 30 years ago moved to Albert Einstein School of Medicine in the Bronx, where she has been now for the last 30 years. She has written over 200 articles, has published a number of books. She continues to publish. Her most recent book, in fact, will be coming out this year, called, maybe it already has come out already, called Global Health Research, Policy, and Practice. Ruth has been very involved in global and international health. She's been very involved in research ethics, in pediatric issues, and HIV issues. She is a member of the Institute of Medicine and has spent time advising the CDC and has been very involved with the World Health Organization and many of its bioethics issues. And she's really, it's really a privilege to have her join us for the day. So I won't say anything further, but welcome you here, and I'll put your slides up, absolutely. So let me just, you are, from the beginning.
Need to go from the beginning.
Oh, yeah.
Forward to the beginning. There we are. Well, it's a pleasure and an honor to be here, and I want to thank Ben for inviting me. I had a look yesterday at my predecessors in this lectureship, and a very distinguished group. I also noted that, is this the sixth year or the sixth year that I'm the first woman in that group? So I begged Ben to have a little gender balance in the future. So. Let me start with this. This is a very, very practical presentation. There's virtually no theory in it. Some of you will be happy to hear, and others may be dismayed. And I have more questions than answers. So I see those microphones up there, and those are presumably to ask questions at the end. But in fact, you're going to give answers, because I'm asking the questions, and you are the clinicians, the practitioners, the physicians, and others in the field of medicine and health, and you're going to give the answers. So here's the question: the whole truth and nothing but the truth. Disclosure of medical information to children. It's an old issue. I don't think there's anything brand new, but as you'll see from the presentation, there are some specific examples that we have to think about. So here are the topics very briefly in the form of questions. When is it ethical to withhold medical information from children? Now we're assuming, this may not always be the case, but the hard issue, the most difficult issue, is when parents refuse to disclose a diagnosis of serious or fatal illness. The question then arises, what is the clinician's responsibility if the child asks about the diagnosis or prognosis, if the child guesses the diagnosis? I have cancer, don't I, doctor? If the child does not ask about diagnosis or prognosis, and yet for one reason or another, a clinician thinks it is appropriate for the child to know, and when the child is an older adolescent, when we're not now talking about 7-year-olds, 8-year-olds, but 16 or 17-year-olds who are still, of course, minors by law. So those are the questions, and I hope you're thinking already of what the answers are. Now, there's much of this discussion. I'm sure it occurred before HIV. Probably those of you in clinical practice for a lot of years encountered this many years ago. But it came to the fore in publications and people writing about this, largely with the HIV epidemic, and in particular children who were infected from mother-to-child transmission, so-called vertical transmission. So the articles began to appear more in the bioethics literature and in the medical literature surrounding HIV. So I'm going to focus on HIV, but that doesn't mean that that's the only focus. We can certainly apply these same questions and potential answers to other areas. So this is based on some empirical evidence, not just somebody's supposition. These are the reasons, or some of the reasons, why parents are reluctant to disclose HIV infection to their children, and not only for the parents to disclose, but to have anybody tell them. So one is the fear of impact of the disclosure on a child's psychological status, excuse me, and emotional health. Another reason, and again, these may not be, these are reasons that were given by parents when they were interviewed, but these may not be accurate presumptions, that disclosure would reduce a child's will to live. The belief that disclosure of HIV would lead to serious depression in the child, a fear of inadvertent disclosure to others by the child. That means if the parents tell the child now knows that he or she is HIV infected. And this article from which I'm drawing these remarks was written in the early stages of the HIV epidemic. Now, of course, we know there's still a stigma, but the fear, both for the sake of the child and also the family, was probably greater in the early years of HIV than it is today. And this is related to the previous one. In other words, if it's the fear of inadvertent disclosure, the question of whether a child can keep secrets is related. So first you have the fear of inadvertent disclosure, and then why is there that fear of inadvertent disclosure? Because the belief that the child cannot keep secrets. And of course, this is the protective role of parents, protecting the child from social rejection and stigma. And we certainly know that there was and still remains, not as great, but still remains some stigma associated with HIV infection. And guilt about transmission. I'm not sure exactly what this meant. This was a reason, yes, I do know what it meant. It meant the parents, in the case of mother-to-child transmission, vertical transmission, guilt on the part of the parents or the mother in particular for having infected the child. So knowing that you're HIV infected, I mean, now, of course, with adolescents, there are, there's a heterosexual route, and even among those children who were adolescents who inject drugs. But in the early stages, of course, it was children who were infected through vertical transmission. And here, and this was also known from other studies, that parents, in the particular the mother, felt guilty of having been the cause of the child's infection. And then association with sexual taboos, simply because if the transmission is, of course, through sexual means, the taboo, even in talking about sex, from the parent to the child, because you tell the child and the child starts asking questions, and the parent may not be willing or able to answer those questions. So this comes from an article back in 1993. So we're talking here about almost 20 years ago, not at the very beginning of the HIV epidemic, but when children became, when HIV was diagnosed in children. And in fact, the very first diagnosis of this disease in children that was not believed by other people in the field was made by a pediatrician at my own institution, a man named Aryeh Rubenstein. He was the first one who actually observed HIV in children and said that it was called at the time, you may recall or have read about, the gay men's disease, because it was just now emerging in the late 1980s that there were other populations other than gay men who were infected. And this pediatrician, Aryeh Rubenstein, was the first to diagnose it in children. And he was laughed at because they said, what are you talking about with children? But he was, it was accurate. So this was now enough clinicians, enough people had been seeing children who were infected, and by 1993, some of these children were already in pre-adolescent of pre-adolescent age. Here's some more reasons. Parents have difficulty, had difficulty coping with their own illness or the illness of other loved ones, and that difficulty led to an unwillingness or an inability to disclose to their children. Whatever the coping strategies are within families, sometimes they were just insufficient or not well enough developed to be able to address this question. In some families or in some cultures, either families themselves or even within entire cultures, there's a traditional silence around illness and disease. People don't talk about it. They don't talk about it with one another or with anyone outside the family. Limited communication within families is another possibility. Denial as a coping strategy. We're getting into the psychological realm. the belief that the child will not understand. Again, these are all reasons given by parents or reasons that emerged in interviews with families. And children as a hope for the future. Well, of course, there was very little hope at that time. Now, of course, we do have treatments that have turned HIV into a chronic disease and not an illness with a prognosis, with a fatal prognosis. And, of course, a little magical thinking. Avoid thinking of HIV keeps fatality at bay. So there's always a little bit of magical thinking going on. So the American Academy of Pediatrics, of which I'm not a member because I'm not a pediatrician, but I suppose many people in this audience are, they issued a view back then, I think I'll have the date in a moment, HIV in children. This is it, 1999. So this is already 6 years later than the article that appeared in the Hastings Center report. And they published a report on disclosing HIV results to children. And I don't know, I mean, I've read the article that described the report, but what I don't know is whether or not this was actually based on studies, on empirical evidence, because even a distinguished organization, association like the American Academy of Pediatrics might ask doctors what they think and then publish something without the data. I don't know. Someone here may know whether there were studies. So here's what the American Academy of Pediatrics said. Children who know their HIV status have more self-esteem than children who do not. If anybody here has examples to the contrary, when you get up to the microphone, you can enlighten us. Parents who disclose this information have less depression than children who do not. And I think what this means is parents who disclose the information have less depression than parents who do not disclose to children. So this is, again, an empirical claim about depression in parents, which one would expect to have some empirical evidence for. And then the Academy had some recommendations. Disclosure of HIV status to children should take account of age, psychosocial maturity, complexity of family dynamics, and the clinical context. Now, that all sounds very sensible to me, but a question occurred to me when I read that, and that is, do clinicians typically know these things? And if you think both of your own practice and what you know about the various settings and various contexts in which HIV occurs in children, it's very likely that in very many cases there is not a family physician, a family pediatrician. The children may be from a family that uses the public hospital, like the Jacobi Hospital in the Bronx that's attached to Albert Einstein College of Medicine. So when you think of the demographics of the HIV epidemic, both in adults and in children, including those children today, adolescents who become infected by virtue of their own behavior, their own risk behavior, it's not very likely that they have a family pediatrician who is knowledgeable about even the psychosocial maturity, although that might be able to be ascertained in an interview, but certainly the complexity of family dynamics. So that's just a question to think about when we look at these kinds of recommendations. Most recently, maybe there's something that came out this year, but most recently in my search for information were these guidelines from the World Health Organization for children up to the age of 12. And because that's the critical age in which some of the questions or the reasons for parents' non-disclosure, we're mostly talking about those children. We'll talk about adolescents a little bit later. So disclosure of children of their own, to children of their own HIV status. The WHO claims that there is evidence of health benefit, and that is reduced risk of death, and little evidence of psychological or emotional harm from disclosure. So this is just the opposite of what the parents believed to be the case. That is, little evidence of psychological or emotional harm. Disclosure of diagnosis, this is a recommendation. It says that the disclosure of diagnosis is not an isolated event. What they should be saying is disclosure of diagnosis should not be an isolated event, but rather a step in the process of adjustment. So this is the way, as we all know, that informed consent should go in the clinical context or in research. Disclosure of children of their parents' or caregivers' HIV status, because here it's not just the children's own HIV status, but that of the parent. In this case, it would be the mother through which the child became infected. And here, the WHO says evidence of benefit to health for HIV positive and HIV negative children of HIV positive caregivers if the caregiver discloses to them. So this is disclosure not of the child's status specifically, it's of the caregiver, which would usually be the parent, if it's in the case of the mother, but of course it could be something else. It could be foster care, especially in the earlier years and still today, where the infected parents, it might have been the father, the biological father, who infected the mother through vertical transmission infected the child. The parents are no longer alive because there wasn't treatment at the time or sufficient treatment, and so someone else is caring for the children, either a grandparent, which is true in very much of Africa, sub-Saharan Africa, and also in the Bronx and probably elsewhere, and also foster care. So those are the WHO guidelines, and here are their recommendations. Children of school age should be told their HIV positive status. Younger children should be told their status incrementally to accommodate their cognitive skills and emotional maturity in preparation for full disclosure. And then the question is, who discloses? So that comes to you here. The decision on who will disclose to the child should be guided by the intent to improve or promote the child's welfare and minimize the risk to his or her well-being and to the quality of the relationship between child and parent and caregiver. So the presumption here is that it will be, or should be, or will be the parent or caregiver who makes the disclosure, but to the extent that parents are unwilling to do that, the questions arise that bring me here today of what is the role of the clinician, the pediatrician, and others on the healthcare team when the child appears. So, reasons to disclose, and here, to the extent that it's relevant, I just would like you to think of other conditions that other than HIV. Reasons to disclose, and here is what some of those reasons are. This is a very unfortunate way to put it, undisclosed children. And when I saw this after I'd read it, I did not mean undisclosed children, but this is the way the slide came out when I wrote it. So what I really mean is children to whom their diagnosis has not been disclosed. They may develop fantasies about their illness. That is, when they know they're ill. They know there's something wrong with them. And here, I mean, of course, this depends upon when in the course of a disease they are diagnosed, whether or not they're asymptomatic and a test is done for some other reason. But, I mean, let's hold those factual, empirical differences for the moment. They may feel isolated from sources of support if they're not told and they have some suspicions. And they have suspicions based on good reason, whether it's symptoms that they are having or the behavior of others around them. As anybody who has taken care of children, treated children, been a parent of children, or even been a child oneself, which I take it as everybody, we know that children are very perceptive about what goes on, about changes in people's behavior, about people who look away rather than look them in their eye. So the question of feeling isolated may come about simply because a child may wish to have a communication, but let's talk about the parents, because that's mainly the people we're talking about, the worry here, that they don't respond. They may learn HIV status inadvertently. How that might come about, all kinds of ways, from other children, from something they read on a medicine bottle, from something they overhear on the telephone. I mean, all kinds of ways. And of course, children, this is obvious, everybody knows this, children want and ask to know what's wrong, and the question is, what should they be told? then they may already know their diagnosis, but are keeping their secret, waiting for the parent to tell. In my discussions with some clinicians at my own institution, they say this is far more common than anybody actually knows. The children are kept in silence, made to feel by behavior or maybe even explicit rejection that they can't talk about this, and so their response is to keep silent even when they know the diagnosis. So another reason to disclose, and here I think this is the first technical term from bioethics that I use, but it's now so widely used that it's not only people in bioethics who talk about autonomy. This is the developing autonomy of the child, obviously as an incremental process, and recognition of that autonomy. Just to give another example outside this narrow topic, this is why in the area of research involving children, we have the concept of assent to research. Children may not legally consent or give their informed consent, but the recognition that they should be informed to the extent of their ability to understand that they are being enrolled in research and given an opportunity perhaps to dissent from the research. So that's another example of recognition of autonomy in children, even those under the age of 12. Children achieve mastery over their lives as they age, and there's an ongoing and evolving process of involvement with their illness and its consequences. So again, these are some of the reasons to disclose. And now, just to bring in a human rights document, because there is a United Nations, as many of you know, United Nations Convention on the Rights of the Child. These United Nations conventions, treaties, and covenants rarely give extremely explicit direction or information, and yet they say something that is relevant to this topic. This is Article 17 of the United Nations Convention on Rights of the Child, and this states that every child should have, quote, access to information and material from a diversity of national and international sources, especially those aimed at the promotion of his or her social, spiritual, and moral well-being and physical and mental health. So if we put together this statement from the International Covenant on Rights of the Convention on Rights of the Child, if we put this together with some of those reasons to disclose a diagnosis of illness, and some of the reasons that parents give for not wanting to disclose, we might conclude that it would be a human rights violation to fail to disclose. And that would be pretty serious. I see someone a little surprised about that. I mean, once we get into the realm of human rights and we say it's a human rights violation, that's a serious, this is more than a minor ethical error, a human rights violation. So I leave it to your contemplation whether you think the refusal to disclose or failure to ensure that the child receives the information rises to the level of a human rights violation, because that's pretty high up on the scale of, on the hierarchy of ethical wrongdoing. Well, it is true, I just mentioned that human rights provisions are sometimes hard to interpret, and this provision specifies rights, but it doesn't say anything about who has the duty to provide the child's access to information. And if you are familiar with a whole array of guidelines, whether they're specific ethical guidelines, ethics guidelines for treatment, for research, whatever, the ones that are helpful are the ones that name an agent, a person or an organization who has the responsibility to do whatever it is the recommendation says. As you see here, in very much rights language, it doesn't name an agent. It names the recipient, namely the child. The child should have access to information and material, but who's responsible for providing that access to the child? Arguably, in the context in which we're talking about, it should be the parent. But of course, the underlying question here is what's the role of the clinician? And if the parent doesn't provide access, then is that something that the clinician should be doing? Well, other health-related contexts, I've been speaking mostly here about HIV, but we can talk about other examples. This is a quote from Cicely Bach, who wrote a book entitled Secrets, all the way back in 1982. That was before HIV, but this is a very interesting book, and what she had to say was, many children perhaps the majority, wonder at some point in childhood whether they are truly the children of those who call themselves their parents, or whether some mistake or planned exchange at birth brought them where they are. So this is an entirely different context, but actually a very well-known context for people who have worked over the years in adoption. The adoption literature or the practices in adoption is a very, very good example of how there has been a paradigm shift, a complete change from keeping secrets from children about their origins, their parentage and origins, to a complete disclosure. And that is very well entrenched now. Much more recently, not much more recently, but more recently than in the area of adoption, has been children whose biological father was a sperm donor. By the way, every time I hear donor, it's really a vendor. I mean, they're paid. When people sell fruit on the street, they're not called fruit donors. So the men who sell their sperm are basically vendors. And then more recently, of course, we have egg donors who are also paid in this country, not in other countries. So questions about the child's biological origin is another context in which the disclosure question arises, but much less so, I would think, for the clinician, for the pediatrician and others on the healthcare team, because this is within a family, and almost always, although there are, of course, physicians who are involved in the practice of assisted reproduction, the embryo that's transferred is not in a position to get any information at that point, and the physicians who do the reproductive embryologists are long since gone by the time a child might start asking about his or her origins. So secrecy regarding the child's adopted status, and as I mentioned, this is a change in ethical viewpoint over time, secrecy regarding gametes, and consequences when the truth is learned. I once heard a lecture by someone who was an expert in, this was years ago at the Hastings Center. It was probably just before or at the beginning of egg donation. And he was talking about sperm donation over the years. And he was a promoter of disclosure to children about the origins, about their biological father. And he recounted one of the examples that I gave earlier about HIV, or one of the reasons for disclosure, that there may be an inadvertent disclosure at a time when it's least expected. And the example that he gave was parents were divorcing. It was an acrimonious divorce. The mother and the father, the parents were fighting like cats and dogs. The mother was angry at the father, and when the child took the side of the father, who was the husband of the woman, but not the biological father, when the child, seeing all this acrimony, took the side of the father, the mother shouted to the child, "And what's more, he's not even your father." So what kind of a context is that for a child to learn his origin? So these are some of the consequences, or some of a context in which the truth actually is disclosed. So now we come to you, pediatrician's responsibility. And I raise this question because over the years then I was involved in various clinical activities, rounds, consultations, regularly scheduled meetings or special consultations. I very often heard from the pediatrics arena, well, the whole family is the patient. Even though it is the child who is the patient and the subject of various, whether it's research or treatment, the child, you have to treat the whole family as the patient. And so this is a little bit metaphorical, but that's at least what I heard pediatricians saying. So the question then is, to whom does a pediatrician owe primary responsibility or allegiance? To the parents, because they are legally and morally decision makers for their children. And I say legally and morally because even though we're talking about ethics and not law, we do believe we shouldn't be transgressing laws that would prohibit physicians or anyone for that matter from doing things to children without parental consent when that is legally required. And because of the importance of maintaining trust in the physician-patient relationship. If the parents who have to bring the child to the medical center, to the clinic for treatment or for diagnosis, if the parents lose trust in the clinicians, then what does that do to the health or the well-being of the child? And then, of course, when the child is too young to understand or to be involved in decision-making, it's quite clear that the pediatrician must owe the primary responsibility when it has to do with communications and disclosure to the parents. To whom does the pediatrician owe primary responsibility? Well, to children when they are older adolescents, arguably, and now you should be taking notes about what you want to challenge me, because maybe you don't like this one, but this is my conclusion. I should say when these are my conclusions and when they are questions. I think when children are older adolescents, the primary responsibility is to those children who are the patients, to the child and to the law in cases of suspected child abuse. Here, there's no question. When it's required by law to disclose suspected child abuse, it's not the primary responsibility to the parents that's going on here, but clearly this is an example in which the primary responsibility is to the child. And I say responsibility to the law because the law does mandate reporting. And to the child of any age, when parents make decisions against the best interest of the child. Well, that is a loaded phrase. What is the best interest of the child? What is against the best interest of the child? This does not give answers, but it is a prompt for questions. When a colleague who's no longer at my institution, but a neonatologist, a pediatrician who works very actively in the field of bioethics. Some of you may know his name, Alan Fleischman. He's a former colleague and a very good friend. He established neonatal ethics rounds, and we developed a neonatal ethics policy at the time, way back when, in the baby doe era, when these infant care committees were mandated by, was he really the president, Ronald Reagan? Yes. It was a strange era. We called our committee the Neonatal Ethics Committee, even though these were called infant care committees, because there's something about the United States government that doesn't like to talk about ethics. Only when there's money involved do they talk about ethics, but generally speaking, that's why we have IRBs. We don't have ethics committees in this country. We have institutional review boards, and every other country has a research ethics board dealing with research ethics. In any case, this policy that we developed had used this phrase, the best interest of the child, or against the best interest of the child, and this is what the principle that was stated in our neonatal policy. It was parents are presumed to be the decision makers for their infants, because this was a neonatal committee, unless their decisions are against the best interest, are clearly against the best interest of the child. Well, that didn't tell anybody how to act, but it did state a principle, and like any general principle in ethics, it requires interpretation and elucidation. So that was the principle, and it can only be determined on a case-by-case basis, and as we frequently say in ethics, reasonable people can disagree. And reasonable people did disagree in some of those cases. So I invite you to think about what kinds of examples there might be where parents make decisions against, let me say clearly against, the best interest of the child. So the examples are up to you. Now I'm going to switch gears to talk about another example of disclosure or failure to make full disclosure. And since John Lantos was an earlier speaker in this series, I thought it might be appropriate to this recent article. Again, it has to do with parents and infants, but in this case, the people to whom the disclosure is being made are not the children, but the parents. Okay, so this is, I think, the title or a phrase that Lantos and his co-author Meadow use in the article. Truth-telling to parents. So here's a case. This is the case in their article. Despite extensive counseling by numerous physicians, social workers, and clergy, a dying infant's mother and father were adamantly opposed to either a DNR order or withdrawal of ventilatory support. They did not want to give up. They hoped for a miracle. They did not want to, quote, kill their baby. So parents are refusing what the doctors are recommending. And so when no agreement can be reached, then what should one do? Here are the options. Invoke a unilateral DNR order and override the family's request. I see someone shaking her head no. Accede to the parents' wishes and perform CPR as traditionally recommended. I don't see any heads nodding here, but let's see what comes up. So, what the authors claim is that both of those options place the highest value on telling the, quote, whole truth. If the doctors invoke a unilateral, this is what the article says, if the doctors invoke a unilateral DNR, they would preserve their, quote, professional integrity, and the family would be disappointed and angry. Second option. If the doctors perform CPR, the family would likely feel vindicated, and the doctors would be frustrated and angry. So notice that what the consequences are in both of these. Disappointment, frustration, and anger. That's the consequences. In both scenarios, truth-telling is equated with eliminating ambiguity. Has anybody read this article? Do you know what the conclusion is? Oh, good. So there's a little bit of a surprise here. The whole truth. So should one eliminate the ambiguity, or is ambiguity a good thing? So, you know this expression, the slow code, the show code, the fake code, the deception, etc. That's actually what their conclusion is. The most appropriate response to this dying girl and her loving family is an abbreviated code, a short code, a tailored code, an appropriate code, is what the authors say. By this approach, discussions with families about CPR are left deliberately ambiguous. The decision, and this, although not discussed in the article, this always raises for me the question of tolerance for ambiguity, because there's a whole psychological literature and psychology on tolerance for ambiguity and how little tolerance there is on the part of many people. So presumably this is not, it's left deliberately ambiguous from the clinician's point of view, but the attempt quite clearly is to lead the parents to believe that they have done what the parents asked. So the decision about the length of resuscitation need not be discussed with the family. And I would agree with that in general, as a matter that some things are really more medical issues than ones that need to be disclosed. Instead, here, the doctors can say to the parents, this is in the article, we will do everything we can that we think will help, and we will always be here for you and your child. Well, if there's anything ambiguous, there it is. So let's look very briefly before closing on the justification in ethics and what kinds of justifications are available. Anybody who works in bioethics know that there are basically two main streams of thought on how one goes about justifying or how one ought to justify a decision or a conclusion. One is to focus on duties, on obligations, and what's called the correlative notion of rights, because rights and duties go together. Or one could try to justify actions or seek to justify actions based on the consequences. So what were the what were the consequences? Remember, the parents would be angry, the clinicians would be angry, the parents would be disappointed, the clinicians would be frustrated. So if we look at the consequences of these actions, does parental anger justify acceding to their demands when those demands are against the best interest of the child? Now, here's that phrase again, and some in this audience might object that, well, it's not really against the best interest of the child. One does hear about the elderly relative, the frail elderly person, where the family does not want to sign a DNR order, that it can be positively harmful to engage in aggressive attempts to resuscitate an elderly patient that could break all her ribs and actually cause more morbidity without any real gain in the quantity or quality of life. Does the potential physician's anger justify insisting on CPR against the parent's wishes? Okay, so these are the consequences. If we thought we should justify either of the two options based on the consequences, this looks like what the consequences would be, these feelings of the people involved. And going back to our original question, do parents have a moral or legal right to insist that pediatricians not disclose a diagnosis or prognosis to the child? And here again, the question is, what is the justification, and how would we justify based either on the consequences or on duties or obligations? So at the beginning, I mentioned these studies, that evidence from all these studies shows the psychological benefit to the child from disclosure of diagnosis or cancer of HIV. So it looks like if we look at the consequences to the child, if we believe the empirical studies, the consequences to the child of disclosure, and possibly also of the parents, are more positive than negative. So if we weigh the consequences, the beneficial consequences against the harmful consequences, if the empirical evidence is accurate, accurately accounts for what goes on here, the consequences justify disclosure to the child. Now, there is a distinction here. We should always make distinctions. That's what biophilosophers, at least, are best known for, making distinctions, and that is between withholding information and lying. Withholding information, whatever it may be, need not involve an attempt to deceive a child. The child does not ask about the diagnosis or prognosis, and that would be an example in which there's no active deception, it's just withholding information. But lying to the child about diagnosis or prognosis is deliberate deception. The child may very well ask the pediatrician or a nurse at the bedside, "What's wrong with me? Do I have AIDS or cancer?" Since the child might have just heard that word because the child is perhaps in the hospital or in the waiting room in the clinic. So when pediatricians decide to disclose, then, here are a few suggestions. These are my suggestions. First, obligation to parents who are refusing the disclosure. Try to get them to agree. That's the first step. Offer to assist the parents in disclosing to the child. This actually has worked. I don't have any evidence at all for children, but this has worked in couples. When the couples are serodiscordant and one member of the couple is found by the physician to be HIV positive and refuses to disclose to the partner, concerted, thoughtful, respectful efforts on the part of the physicians have actually succeeded in getting the infected partner to disclose to the uninfected partner. So this could work in some situations. If they still refuse, now the case gets harder, and the pediatrician feels an obligation to disclose to the child, then it's ethically necessary to inform the parents before the disclosure that it will take place. And here we're up against the wall where there's some good reason that the pediatrician believes is necessary to tell the child. Offer psychosocial support to the parents to follow the disclosure, which is a reasonable thing to do if the parents are willing to accept that support. And now briefly, just before ending, disclosure to adolescents. Here, I would argue that pediatricians have an enhanced obligation to disclose to adolescents. And this is partly for ethical reasons, to respect the developing autonomy of adolescent patients. Furthermore, the greater likelihood that the adolescent already knows or will readily learn the diagnosis or prognosis. So this is the question of whether or not it's inadvertent disclosure is worse than a deliberate disclosure. The need to promote adolescents' trust in medical personnel and willingness to be adherent to the therapeutic regimen is another reason, because we now know the child has a disease that requires medication. And then here is there an affirmative obligation to disclose, which would make an even stronger case with sexually active adolescents who must be informed of their HIV status because of the risk to others. And that's a duty to protect others, and the physician may have primary responsibility to the patient, but also to the health of the community. And now we know, of course, that there are benefits to early treatment for HIV, which is another reason to disclose, because then you'd have to begin to treat the adolescent. So there's a strong ethical presumption on the side of disclosure. Notice it's not an absolute. There are rarely absolutes in ethics, but a strong ethical presumption. Better emotional and psychological consequences for the child. It enhances communication and trust between physicians and the child and the parents. It guards against the child finding out the information in a distressful situation. And I would argue that even though there are obligations to the whole family and obligations to the parents of children, especially young children, the physician's primary responsibility is to the patient. Normally, the interests of parents and child coincide, and the pediatrician is obligated to both, so you don't have problems all the time. But when parents say, do not disclose to the child, I would argue the obligation to the child takes precedence over the obligation to the parents. And in this case, the question is how, when, under what circumstances the disclosure should be made, and not whether it should be made. But, of course, still it remains important not to alienate the parents or have them lose trust in the medical team. Well, finally, complications. What if the child asks the nurse and the pediatrician has decided to go along with the parents' wishes not to disclose? Okay, here's some questions without answers. Same question in the hospital context, and the child asks the pediatric resident. Pediatrician goes along with the parents, and the child asks the resident. Same question, and the child asks a medical student. Now we're getting down in the ranks here. What if the parents are both present, and what if they disagree? That is, the parents disagree between themselves about disclosure. Complications. Finally, the research context, and that is, we've been talking so far just about treatment. The obligation to disclose the diagnosis to the child, I would argue, is stronger in the research context because the child who's capable of assenting to research cannot provide meaningful or appropriate assent in ignorance of the diagnosis. And here we're talking about the ability to understand what research is and the ability. Okay, I'm finishing. Researchers could not accurately state the benefits of the child's participation in research without disclosure, and researchers could not accurately describe the procedures without saying what the procedures are designed to accomplish. So I argue there's a stronger obligation in the context of research than there is in the clinical context, but as with disclosure in the clinical setting, the strength of the obligation may depend on age and other factors. So my conclusion: strong ethical presumption of the child's right to know. Is it a rebuttable presumption? That's a little bit of legal jargon, when can you rebut the presumption? Strong presumption that parents are the best decision makers for their children, and yet that may be, in some cases, a rebuttable presumption. And the consequentialist solution to this dilemma requires reasonably accurate ability to predict the consequences of non-disclosure. And it's something we human beings are really not very good at, predicting the consequences of our actions. So that's it. And now we have time for your answers.
In the tradition of this model, we'll ask you to come to the microphones. That also allows us to get some idea of how many and what questions are going to be asked.
I'll start waiting for the people to come to the microphone. It's on now. Yeah, I'll go ahead and start waiting for the people to come. I had a lot of things to ask about, but so I think I'll ask, rather than trying to answer your questions, I think I'll try to ask you another question related to the complications. You suggested that often the way we should try to approach this is when if there's disagreements, take a little more time. It's a matter of when, how to do this. Recently, we were leading some discussion groups for the nurses about bioethical issues, and they raised an interesting example of non-disclosure that was a little more challenging because of the immediacy of it. And this is a circumstance where a child is coming in for surgery, and the parents disclose to the nurse, "Don't tell him he's having surgery today. We haven't told him that yet. We want to wait till he wakes up."
So I'm going to ask another question because I don't have the answer. How old was this child?
Let's say around 8.
Well, So what's the question?
The question is, what should the nurse do? Should the nurse, I mean,
Well, the problem with this is that there's not enough time to go through all those steps
Right.
that I mentioned. I mean, imagine the response of the child when the child wakes up, right? I mean, the consequences of a child of an age of understanding not being told something, waking up in a hospital bed, possibly in pain, having to take medication without having been told. I mean, that could be, there could be all kinds of consequences to the child. If there's no ability for the nurse to convince the parents in that case, then presumably one has to go along with what the parents say, but then the parents are going to who are going to suffer some of the consequences. So unfortunately, in some contexts, there's not enough time to explore all of the likely consequences. All right, I'm going to go on to others here because I see someone.
First of all, thank you for what is an incredibly important topic. My question is related to if you think there's a way to kind of standardize the procedure of determining whether a child is ready to have the disclosure. So thinking about in terms of like competence assessment, like competence to be able to make a decision about a medical procedure, or, you know, it's in the adult literature, I mean, typically you can go through like a psychiatric evaluation, or there are even like models for the primary physician asking specific directed questions to determine that level of competence. And then, you know, in some cases, people are deemed not to be competent to make medical decisions, and then, you know, it goes down that pathway. Do you think that there's a role for that?
Well, I think it's very hard to standardize. I mean, I would question, but some here may reject this question. I would question whether a psychiatrist or even a child psychiatrist is better able to make a judgment of competency than an experienced pediatrician or clinician who's had experience with children. But there are so many dimensions to competency. It's not only cognitive. Usually when we think of competency, and that's what the evaluation, for the most part, concerns, is cognitive capacity, not only to understand, but to appreciate the consequences or appreciate the effects of what one is being told. However, it's more than cognitive ability here. We're talking now about the emotional consequences, the psychological consequences. So I think it would be difficult to standardize to make it a routine practice, but it's certainly something that, just as clinicians might be looking at what the capacity is of a child to understand in general, that would apply as well here. So there is a role for it, but the question is, how is it done, and is there often time to do it?
Hi.
Hi.
I was wondering what your thoughts are on disclosure to children who have disorders of sexual development. A simple example would be a child who is chromosomally one gender but appears physically to be the other gender, and if you thought the same principles applied as far as disclosure and when.
Well, that's a big topic. I actually, I think that is pretty much age dependent. Since we have to imagine a whole lot of background knowledge on the part of a child about sex and gender and the future. The only ways in which I've thought about it's a very interesting question about disclosure, because the question of, for example, ambiguous genitalia and whether or not to perform surgery, which has been around for a long time, and even there, views are changing about the appropriateness of doing that kind of surgery, and there's fierce controversy about it. Surely, at some appropriate point, and I would say probably pre-adolescent or close to adolescent, around puberty, is a time when this must be raised. But I guess the possibility of children not only not understanding sufficiently, but feeling too different and too unlike everybody else that may come with disclosure, says that's probably an age-based thing. And here I think there must be experts. Unlike my answer to the previous question about whether to call a child psychiatrist, here I think somebody who is skilled, knowledgeable, and experienced in matters having to do with children's sexuality should be involved in that kind of disclosure. Because often the parents can't make that disclosure. They don't know what to say.
Thank you.
Is this the last question?
Wonderful presentation, thank you. How would you counsel a care team organization and the family in dealing with the disclosure of a child who was harmed by medical care, by medical error, early in life, before, as an infant maybe, and now they're old enough to understand, maybe they have a shortened leg, or how would they tell the family what to say, when to say? How would the care team be involved, or the hospital involved? What would you counsel them?
Boy, you guys are asking hard questions. Well, I think that's an example, and this is right off the top of my head. I think that's an example of when the child asks, there's a need to disclose. And probably most children will ask. I'm not sure, and I guess I'm saying this with uncertainty, whether there's a need to provide this information if a child doesn't ask. Now, assuming that there's a loving family and the child is supported by the family and there's all, I mean, you're asking now about the health team disclosure. The parents may themselves decide to disclose, or they may not want to. The question of whether or not the same people are involved who were causally responsible when the child gets older and old enough to understand this, I mean, that's a factor, I think that's relevant here, because it may not be the very people who were responsible for the medical error who are then caring for the child later on. And surely that burden should not be imposed on people who had no role in the initial episode. So again, very often, as we know in bioethics in cases, you have to look at all of the relevant circumstances. So here, I guess I would say it's imperative not to lie to children when they ask a question. But what is gained in this case by informing the child, that is a possibility of doing more harm than good. If a child then begins not to trust medicine because not to trust doctors because they were responsible for a lifelong disability of some sort, that would be a bad consequence. But again, it's only surmise that would be, or supposition that would be the consequences. So I will leave you to your deliberations and difficulties in answering these questions. Thank you very much.
Big hand, please. Thank you.